Hello, welcome to our 90-minute tutorial here at ACM Fact 2021. Today we'll be talking about from publishing to practice, bringing AI model governance to a healthcare setting. And by the end of this 90-minute period, you'll know what each of those words mean, and you'll have learned both from the AI practitioner side as well as from the stakeholder side, some baseline steps on how to implement and sort of govern AI models in practice. So a quick outline to today's discussion. So I'll kick things off. John Dickerson, I'm Chief Scientist of Arthur. I'm also an Assistant Professor of Computer Science at the University of Maryland. I'll kick things off with a 15-minute discussion motivating from the AI practitioner side, the publishing to practice pipeline that I've gone through in the context of a single application called Kidney Exchange. Following that, we'll have Brian Powers, who's Deputy Chief Medical Officer of Humana, discuss sort of from the other side, what it takes to bring AI governance to a healthcare setting. We'll take a quick pause for about 5 minutes to take questions, and then we'll give some answers to those. Following that, we'll have a fireside chat with Liz O'Sullivan, VP of Responsible AI at Arthur, with Brent Sundheimer, who's Principal AI Architect at Humana, discussing practitioners' sort of experiences in an enterprise healthcare environment. And finally, Liz will then moderate a panel of experts, including Dr. Rumen Chowdhury, who's CEO and founder of Parity AI, along with Director of ML Ethics at Twitter, Lofred Mazzo, who's AI project lead at the World Economic Forum, and then Brian and Brent as well. And they'll discuss some sort of their experiences in this space, and then we'll have a Q&A session at the very end of that. And I will mention that we have folks who are feeding us questions from Slido with about a 30 to 45 second lag, so do feel free to dive in there. So I'll kick things off, sort of setting the stage with a specific set of 2 case studies in one application area, which is organ allocation. And a quick spoiler is that AI, broadly defined, already plays a big role in organ allocation. So there's active research in this area, but AI in general is playing an active role and has played an active role in organ allocation, both in the United States as well as in the EU for quite a long time. So let's talk about this. Let's set the stage. I'll do this from the United States because this is the area with the most experience from my point of view. But these sorts of numbers, these trends that I'll show you are similar throughout the world. So in the US, around 100,000 people are on a waiting list for a kidney at the moment. So why would you be on a waiting list for a kidney? Well, when you have end-stage renal failure, there are a couple of ways to stay alive. One is to stay on dialysis, wherein blood is taken from your body, filtered by, say, a machine, and then put back into you. This is a costly endeavor, both in terms of money and in terms of quality of life hit. Another way to stay alive is to receive an organ transplant. So these are scarce resources, and there are not enough to go around at the moment. And so there is a waiting list of around 100,000 people in the US for kidneys. And between 35 and 40,000 people are added every year. And unfortunately, around 4,000 die due to kidney-related issues while waiting every year. Around 15,000 will receive a kidney from what's called the deceased donor waiting list. And this is when a cadaveric kidney, so somebody dies, unfortunately, of, say, natural causes or due to a car crash and is a willing donor, here an organ can be harvested from that cadaver and then quickly dispatched according to some sort of prioritization set of rules that are set up in part due to sort of AI and sort of standard statistics due to people who are waiting on this waiting list. And about 15,000 will receive a kidney from the deceased donor waiting list. About 6,500 will receive a kidney from a living donor. And all things considered, it's actually better to receive a kidney from a living donor. So there do exist, of course, more powerful kidneys from deceased donors. But if I had to choose, put on my Rawlsian veil of ignorance, if I had to choose a deceased donor kidney or a living donor kidney, I would choose the living donor one because it's going to be more powerful in general. It's going to last in my body and do a better job of filtering blood than the deceased donor kidney. So about 6,500 people receive them from living donors. Some of these are through kidney exchanges. Okay, and so I've experienced working with some large field of the kidney exchanges. Obviously, I don't speak for them in this talk, but I do have some experience in this space. So what's a kidney exchange? Well, here's the most simple kidney exchange. We have 2 patients. These are folks who need a kidney. And each of them knows a willing but potentially incompatible donor. The husband's wife, for example, may be willing to give him a kidney, but perhaps she has the wrong blood type for him. Similarly, these 2 brothers, well, one is willing to give a kidney to the other, but perhaps he has the wrong tissue type, or there's some other logistical or healthcare issue. So in a world where these two patient-donor pairs do not know about each other, two willing donors do not give, and two needy patients do not receive. But the idea behind kidney exchange is to form an organized barter market wherein patients enter into the market with an endowed good, in this sense, donors willing to give a kidney. And potentially the wife here could give to the brother, and the brother could give to the husband, and everybody would leave happy, right? So the wife cares only about her husband receiving an organ. She's willing to give an organ if and only if her husband receives one. She doesn't care if it's coming from her or from somebody else. So we can view these as, from a computer science point of view, sort of large directed graph problems. Okay, so we can view each patient-donor pair in this space as a vertex, and then we can draw directed edges from a vertex to another if the donor at the first could potentially give to the patient at the second. So here I've drawn a 2-cycle where we have 2 vertices and we have 2 edges, and I've been able to find a cyclic swap here, which is feasible, legal, aligns with the incentives of the patients and donors, and so on. Now, these structures can get more complicated. For example, I could define a 3rd patient-donor pair, and then folks could actually interact via a 3-cycle or a 4-cycle or a 5-cycle. And there are all sorts of logistic sort of limits that come into this that prevent, very sort of exotic, very long cycles from occurring that are a bit outside the scope of this talk. Another sort of structure that we might think about, and one that introduces a set of different sort of ethical, I won't say issues, but ethical considerations, is where a donor comes into the market without a paired patient and just says, you know what, I would like to give a kidney to somebody. I don't need anything in return. I'd like to pay it forward. And these are often called non-directed donor or angel donor or altruistic donor initiated chains. So in a setting like this, we have somebody come into the kidney exchange. They give one organ to a patient who has a paired donor who gives to a patient, who has a paired donor who gives to a patient, who has a paired donor who gives to a patient. And these can go on for a very long time. Indeed, here's a screenshot from the early 2010s in the New York Times with a 30 length chain. So it involved about 60 people. And more recently, for example, the University of Alabama at Birmingham worked on a multi-year chain that included over 100 people. So these can go on for a very long time, but a bunch of things can go wrong while you're doing this over multiple years. And so when you're running a planning algorithm, you typically put a cap in here, or you typically downweight very long chains when you're talking about a single match run. So how does AI fit into this? Well, let's look at how things currently work sort of from a 10,000-foot view. Exchanges run match runs. What this means is you identify a pool of patients and donors, and that identification process can include a machine learning element to it. For example, I might want to estimate sort of the quality of matching donors and patients. For example, one donor might be better, all things considered, than another donor for a particular patient. And I can learn this from data, or maybe I can encode into this concerns of fairness that have been discussed by committee. Now, there's some sort of information gathering that might go on as well. For example, in some exchanges, after identifying a potential kidney exchange pool, the exchange will actually go and via some costly interaction with, say, surgeons, nephrologists, and so on, they'll ask for additional information to try to reduce the uncertainty in the pool. For example, if I were to offer this donor to this particular patient, would you actually take it or not? And again, active learning might play a role here. We have a paper, for example, at NeurIPS 2020 that takes a Monte Carlo tree search approach to trying to reduce this. Now, after determining the information that should be fed into a match run, an optimization algorithm is run, wherein cycles and chains and cycles of various lengths and different weights and different risk profiles are chosen algorithmically. Now, once these are chosen, patients and donors are notified, additional medical tests are run, operating rooms are scheduled, doctors are scheduled, nurses are scheduled. Some things fail before transplantation, some things don't fail before transplantation. If there is a cycle or a chain that has no failures, then it goes into transplantation and the system gets quote unquote utility. So at each of these three stages, there's already statistics, machine learning, and what I'll call sort of hardcore combinatorial optimization, or AI, in place in exchanges in the US and worldwide. Now, there are a lot of moving parts here, right? There's distribution drift. For example, supply and demand might shift. The demographics of countries change. As a country gets older or younger, the need for kidneys might change. as say racial shifts might change, different underlying distributions from which you're drawing blood types. The increase in obesity or the increase or decrease in alcohol use might change the demand for kidneys. There may be shocks to the system. For example, in Canada, this is a very recent article I saw in the last week, there's been a 30% drop in living donation and a 21% drop in deceased donation during the COVID period. Now, the living donation drop is in large part because maybe people don't want to go to a transplant center for something that is voluntary right now. The deceased donation drop is a little more interesting, I believe, because this is due, I mean, you can make a causal argument for this being due to increased usage of ICUs. So how would a system that's running an automated matching algorithm manage to monitor for and then handle this sort of shock to the system? Concerns of fairness are everywhere in organ allocation and also healthcare, obviously. Race plays a huge role in the probability of being matched and the expected match quality. And this has been known for quite a long time. I have two screenshots here. Here's a JAMA article from the 90s and another recent one in the New England Journal of Medicine in mid 2020, discussing sort of the inclusion of various race factors in prioritization in medical systems in general, but also in organ allocation specifically. Socioeconomic status, access to hospitals, age, geographic location is a big one. Steve Jobs, for example, famously took advantage of this. Access to information. Do I know that particular systems exist? Health characteristics. I'm born with a blood type that's hard to match versus I'm born with a blood type that's easy to match. I may be prioritized or I may be deprioritized because of that. And sort of more non-obvious ones, like having had children. If you have children, you build up antibodies to the person with whom you had children, who's also most likely to be your potential donor. So these are all concerns that one must think about, both from the optimization point of view, but also obviously from the legal point of view, from the ethical point of view, and so on. And there are many, many, many other moving parts here. The legal landscape changes across different countries. Social norms might change. For example, a big one is money is not allowed explicitly in organ markets in almost every country in the world. International exchanges. The European Union right now is booting up a formal international exchange program. How does money play into this? How does insurance play into this? From a computer scientist point of view, how does the complexity of the problem to solve play into this? There's noisy data, there's incentive problems. Here in the US, we have insurance companies, we have various different agents, right? Dynamics in the system, competition, and so on. So AI, data scientists, computer scientists, we play just one role in this. Researchers also play just one role in this. This is really just a function of many different stakeholders, right? The medical community, the research community, the world, the legal community, and so on. And this is a big, messy function. So I, as a researcher, focus on primarily optimization-based approaches to clearing these large markets. I'm one part of that very large system. And I thought today I would kick things off by going over a couple quick experiences that I've had translating publishing into practice. The first one is a well-defined problem. Okay, so exchanges have wondered in the short term for a single match run, not over time. Over time, long chains are great, but for a single match run, should I plan a long chain or should I plan a short chain? It's a reasonably well-defined problem. Okay. So let's think about why I might want a short versus a long chain. Here's a for chain, right? We have a non-directed donor, this angel or altruistic donor, kicking off a chain. Now, the first transplant could exist, and then something could go wrong. Or the second transplant could exist, and then something could go wrong. And the third transplant could exist, or something could go wrong. Or the fourth one could exist, and something could go wrong. Should I, during optimization, cap this off? Should I downweight it? How should I plan in the short term such that I maximize some objective over time? This is a reasonably well-defined problem for a computer scientist to handle. So we thought about it. Now, obviously, there's this feedback loop between stakeholders and technicians as we spec out the project, right? So the spoiler here for this entire talk, and in fact, this entire tutorial, is to work with stakeholders. In our case, we gained an understanding of the problem from the stakeholders. We thought about this from a theoretical point of view. So we used random graph models. We used sort of your standard data mining approaches to gain an understanding of the theory side. We then created a very realistic optimization-based approach to tackling the problem. We simulated, we talked to stakeholders. We simulated, we talked to stakeholders. We simulated to sort of understand what an implementation of the idea would look like in practice. And then, again, spoiler, we worked with stakeholders for a policy recommendation, iterated. You're always going to get things wrong in your model, in your optimization-based approach, in your simulation, and then push to change. Okay. So in this case, we published a paper in 2012, and it took about, I would say, 2 to 3 years before an implementation went into practice. And that, I would say, is actually, especially in the healthcare space, a pretty reasonable fast turnaround. Okay. That's for a well-defined problem. I'd like to give an example of a sort of less well-defined problem. So here is an introduction of a new, and sort of, I won't say it's not obviously okay in the sense that it's not been thought about before. And so people, it's not a white and black sort of, this is legal, this is not legal, this is ethical, this is not ethical. It's a new idea. So how would that propagate into practice? Well, here's an idea. Kidney exchanges are ubiquitous at this point because the waiting list for kidneys is so long. There's a lot of demand, there's a lot of supply. It's a reasonably low risk operation. It's well understood and so on. But there's no reason why one couldn't make an exchange for other organs, for example, like a liver. It's a similar matching problem, actually, mathematically at least. There are some nuances from the medical point of view. For example, I could actually use 2 donors if I needed to. And there are different risk profiles for different parts of the liver, not really important for the scope of this talk. One could set up a liver exchange. In fact, there have been ad hoc liver exchanges, non-algorithmically run for a number of years, I think kicked off initially in Korea and now worldwide as well. Okay. And there's a good sell for this, which is that exchanges, if I were to deploy this, might actually reduce the use of riskier bits of the liver and may increase, for example, total transplants or decrease total mortality or morbidity or other sorts of metrics that you would like. Great. So this is an idea that most would not find contentious. And in fact, they have been going on in an ad hoc fashion for quite a long time. Now, with my advisor, Thomas Sandholm at Carnegie Mellon University, when I was a PhD student, we published a paper extending this even further. Okay, so this is a paper that appeared in 2017 in the Journal of AI Research. We thought, hey, this chain idea is great. Chains cause, actually, if you look at efficacy in present day fielded exchanges, these chains are the real powerhouses. They're the ones doing most of the matching work. We know that kidney transplants are, I have in quotes here because obviously it's not easy, but they're relatively easy and they're popular, right? You read about people donating kidneys all the time. These exchanges have sort of high numbers of folks in them. There are many non-directed donors. With liver transplants, though, there's higher mortality to the donor. There's higher morbidity to the donor, which leads to a large drop in the number of non-directed donors who are available. Okay, so if I were to have a liver exchange, I likely would not have as many non-directed donors, which means I likely would not have as many chains, which means I likely would have not as much transplantation going on. So the idea here for multi-organ exchange, and I'm saying this is not clearly an obviously okay idea because there are ethical issues that arise that I'll discuss in the coming slides, would be to take a non-directed donor who gives a kidney. It's extremely unlikely that the non-directed donor would want to give a liver, but there are many that do give kidneys. They give to somebody in the kidney exchange. This person has a paired donor. That donor gives a kidney within the kidney exchange. This person has a paired donor. But the incentives of this paired donor are different than the incentives for the non-directed donor. This paired donor here might be willing to give a liver instead of a kidney. And at that point, we could thread this chain into the liver exchange, gaining some of the power of that chain structure without needing an initial non-directed donor who gives a liver. And this chain could go back and forth between the different organ exchanges. Okay. So we showed in this paper, it's a very sort of theory-heavy paper. We showed a random graph model that results in, linear gain in the number of, fill in the blanks in terms of nice theory, but a large gain in the pools if you were to combine kidneys and liver exchanges versus 2 exchanges separately. And then we showed in simulation that these gains would be quite stark. And this is realistic simulation. And we published this and thought, what, it would be awesome if this happened, but we don't know how to get it into practice at the moment. Now, there are these ethical issues that I mentioned. For example, patient-donor pairs would now be exchanging different goods, right? A patient-donor pair, a kidney comes in, that pair gets a kidney and then gives a liver. And these are different goods. And there's a different risk profile. There's a 600% increment in mortality risk for liver versus kidney donors. Okay, so there's about a 1 in 3,000 risk of death for kidney donors. There's about a 1 in 500 risk of death for liver donors. Okay, so that's an ethical consideration to take into account. But in April of 2019, some folks at UCSF published a paper in the American Journal of Transplantation saying, you know what, we did this. And there's an interesting story behind this, which is that the liver donor read the paper that we published in the Journal of AI Research, thought that this was already a fielded idea instead of a theoretical idea in an AI conference or in an AI journal, and then walked up to a surgeon and said, I'd like to do this. And the surgeon knew, hey, this isn't a thing that has happened before. So he started working with the ethics committee within his transplant center. And they discussed some of the issues that I've discussed here and decided it was okay. And the first bi-organ paired exchange occurred. A liver was exchanged for a kidney for the first time. So there was real world reasoning about ethics that occurred here. I have a couple of lines here from some press coverage that occurred, the Washington Post and New Science, discussing some of the ethical considerations that occurred in the IRB for this transplant center. One of the big issues was that the life-saving power of a liver versus the life-enhancing power of a kidney had to be discussed. What do I mean by that? Well, a liver, there is no version of dialysis for end-stage liver disease. And so in some sense, getting the liver is the only way to stay alive versus getting a kidney, well, you can stay on dialysis. So it's life enhancing. And there was an argument that the power, the benefit of both organs was not the same. And from my own personal point of view, I'm glad that this IRB came down on the side of balancing that out. The idea here being that dialysis for kidneys has a high mortality rate. Getting a living donor kidney versus staying on the deceased donation waiting list without a kidney has a similar mortality risk to getting a liver transplant. There was all sorts of discussion about whether or not double equipoise was being adhered to. By this IRB, the answer was yes, and then this occurred. Okay, so this was a very different process than the one that we had in a previous case where we worked with stakeholders directly, we had a problem, and then we went back and forth and they deployed a solution. This was one where we published and then somebody read the paper and took it to a doctor and they handled some of the ethical issues and then went through with it. So this is an example again of, well, different ways that one works with stakeholders who define different wants, communicate with technicians who then decide how to design options for tackling the problems that stakeholders express that they want. Those stakeholders then see the options that pop out and maybe refine what they think they want or deploy the actual process. Okay, so this is a large feedback loop. In practice, there are all sorts of feedback loops within this. Technicians have feedback loops within themselves, and so on. This is a messy, messy process, and it's one that I will now hand off to Brian Powers to discuss from the other side.
Great, thanks, John. I'm just getting my setup here. All right. Yeah, so I'm really excited to be part of this group today and continue the discussion here on representing a stakeholder perspective on how we take findings from research that a lot of this community does and bring it into practice. And I think a really fun thing for me is getting to straddle both sides. So one thing I'll be speaking about today is a specific case study and going from publishing to practice, where we took research that I was involved in about 1.5 years ago, and then extended that over to our work here at Humana today. And so I'll start off by just, as representing the stakeholder perspective here, just giving you all a sense of us as a stakeholder, of what who Humana is. So for those of you not aware, Humana is a very large health and well-being company. We serve millions of Americans, provide healthcare services to millions of Americans. Both insurance services is a large Medicare Advantage plan and a provider of benefits to commercial and military members. And then also is a very large healthcare services company with a large pharmacy, large home health, primary care, and behavioral health presence. We, as an organization, have a firm commitment to fairness, equity, and diversity in all that we do. And that permeates our commitments to our different stakeholders and how we work with our different stakeholders, what we ask of our different stakeholders. First and foremost, as a healthcare company, is a commitment to fairness, equity, and diversity when it comes to our members. And that really motivates our commitment to health equity. I know this audience is not one that we need to make this point deliberately too, but I do think it's always helpful and grounding in these discussions to remind ourselves of the really significant and unacceptable barriers that we face with respect to health equity. And I think it motivates both us embracing algorithms and AI as a way to ameliorate those disparities, but also makes it clear that how attentive we need to be to ensuring that algorithms are not perpetuating these same disparities. One to call out specifically here is around what we've seen during the COVID pandemic, and a couple numbers on the screen here. But as I imagine most of you are aware, the pandemic has taken a unacceptably disparate toll on our communities of color, socioeconomically disadvantaged communities, both when you look at incidence and burden, the economic impacts of the pandemic, and most troublingly, morbidity and mortality associated with the pandemic. Also, not news to anyone here in this audience, but there is, of course, a growing concern that our reliance on algorithms may be perpetuating some of these inequities, both in the healthcare industry and beyond. And there's a growing awareness and growing attention to this, and reflective in this very conference, being established over the past couple of years. And many members on the panel and folks in the audience have contributed to this growing understanding of algorithmic bias. And I think through it's moved from theory to practice, even in the research side of what used to be maybe conceptual or theoretical concerns over how algorithms could perpetuate or create new biases and disparities in health, to more recently discrete examples of how that's been the case. And as I'm going to highlight two of those examples now, one good and one bad. So this is a paper that I was referring to earlier. So this is a paper that I published with some colleagues in Science in late 2019 that was looking at the racial bias in a population health management algorithm. And this, we could spend a whole 30 minutes or longer talking about this specific paper, but I think the key point here is we have a growing awareness, and now this is a prime example of the fact that without proper attention, algorithms that may be well-intentioned or not be perhaps on the surface have the potential to contribute to racial disparities or to perpetuate other forms of healthcare inequity, can do so without proper care and proper attention. At the same time, highlight a more recent paper from a colleague, not one I was involved in. We have more data now that algorithms can be a force for good. So it's not that algorithms in healthcare are bad or algorithms in healthcare are undermining our efforts at health equity. Those would be sort of inappropriate categorical statements in either direction. They're not inherently good or inherently bad. It's about how you develop them and how you implement them. This specific paper showed that by leveraging deep learning and a more representative, both from racial and socioeconomic perspective, training set, you can actually limit the racial disparities that are seen when judging the severity of pain or osteoarthritis when looking at x-rays. So just one example of how when you, with proper attention, with proper care, by working in this case with clinicians and other stakeholders, we can use algorithms to, as a force for good. Talk a little bit from our perspective as Humana why we care about this. And John mentioned, AI and algorithms are guiding healthcare at large right now. This isn't something that's relegated to computer science journals or to some fringe companies that are sort of out ahead of everyone else. Algorithms touch most Americans when it comes to healthcare, and the scale and scope of AI and algorithms at Humana specifically requires us to have a deliberate and structured approach to algorithmic fairness, accountability, and transparency. Brent will go into this in a little bit more detail, but we have over 300 algorithms in production. Those algorithms contribute to over 1 million member touch points every day, and the applications are vast. They span from marketing to clinical programs, and we can't afford to get this wrong. So what have we done as an organization to focus our energies around making sure that those algorithms are advancing the goals that we're committed to as a healthcare company, and not causing any undue harm? And here's an overview of some of those principles that we've aligned on as an organization. And we think about AI governance, it does really start at, this can feel high level on paper, but it's essential work to start by working across the organization. This is not a data science exercise. This is not a clinical exercise. This was really an effort to bring together the entire organization. Clearly, the algorithms and our use of AI impact the entire organization. And so by bringing together those representatives aligning on a core set of principles, it is much more than an exercise to get a couple of principles on paper. It's affirming and being very clear about our commitment. And when you have an organizing set of principles like that, it becomes very easy to then trace back our activities, both to prioritize investments and support investments, and then also check ourselves along the way. As a physician, I do like us leading with the Hippocratic Oath here of doing no harm, and that's really the guiding principle here. Is that AI needs to be a source for good, needs to further our commitment to our members, and we really do commit to first doing no harm. The one to focus on more today, I think all of these we could spend hours on. Fairness and inclusivity is probably what we'll spend the most attention to here. But I think the key thing here is more a process point, which is that we did go through this deliberate exercise to speak to our work across the organization and really align on these principles and commit to them. Another important thing is that we committed to it publicly. So Humana was the first health insurance company to take the Equal AI pledge. And this too was an effort to really align the organization and just publicly commit that we will take steps to audit our algorithms for any form of bias or lack of fairness. And when if we find evidence of fairness or bias, before we get to the implementation stage, we'll take steps to correct it. And that we'll also be part of this broader community, represented by members of the panel today, and then also a lot of the attendees, to hopefully advance science and advance the practice around how do you implement fair AI and equal AI in practice. I'll end with a little bit of a case study and how we've learned. And so this is the paper that I mentioned earlier, came out in late 2019, one that I was involved in. And I think this is a great example of how you go from publishing to practice. And it does, I think the common theme, as John mentioned, is it is starting with stakeholders in close partnership with stakeholders. And I think we'll touch on that a little bit more in the panel. But I would say if I was to summarize the key takeaway from this paper is that the choice of the proxy that the algorithm was predicting was not in fact how it was implemented. And that was the source of bias. It was by using, and we're forced to use proxies, but the proxy that was chosen, in this case cost, is what was really intended was patient health or patient need. That resulted in racial bias. And so how do we take that one learning and how do we translate that to what Brant, I, and others are doing at Humana? So I think it starts, and this is back to the stakeholder point, with assembling a diverse team. And that's diverse in all sense of the words. You need a diverse set of perspectives, both lived experiences, demographics, socioeconomic status, and where in the company, and in this case, in our company, you sit. You need to understand how the algorithm will be used. You need, if it's being deployed in a clinical setting, you need to understand, you need to have clinicians at the table. If it's going to be deployed in a marketing setting, you need to have marketing representative at the table. You can't design an effective, let alone fair algorithm without a really deep understanding about how it's going to be used. That flows quickly to sort of principle or approach 2 here, which is to spend time upfront investing in problem formulation. And that is, what is the actual question we're trying to solve? Is this algorithm predicting the thing we really care about? And our take from this paper was, if a little more time had been invested up front, we know that due to structural racism, cost is a biased proxy for healthcare needs in the case of this paper. There's a lot of people involved. That's not new, unfortunately, right? And I think the challenge here is that question wasn't asked, and so it didn't come up. And So it's important to, when you have a diverse multi-stakeholder team, to spend time thinking about, sometimes there are biases we don't know about, obviously, and we'll get to the, in a couple steps down, but let's at least inventory and think about the biases we know about and whether there's an opportunity that those forms of structural inequality will creep in to this specific prediction problem. Number 3 is more specific to this paper, maybe than to other implementations, but we're often, especially in healthcare, forced to use proxy labels. We can't measure a patient's need for care management or need for population health management. That is not a discrete variable in a data set. But if we're answering our prediction problem, we have to train our algorithm to an output. And so we do have to choose a discrete variable in a data set. And that's an inevitability to some degree in certain prediction problems. And so if you're forced to use a proxy label, again, significant time up front should be dedicated to interrogating those proxy labels. And Brent and I can talk a little bit more about how we're doing that at Humana. And then once you have then built first iteration of your algorithm, is to audit for bias. And there's a number of different fairness metrics, and I don't know if we'll get into that or if we need to get into that even in the panel today. I think the key point here, and again, it flows back to that stakeholder and multidisciplinary team point of view, is that you have to audit for bias with the right metrics, and it can get pretty complicated pretty quickly. Even with the same algorithm, the metric you might use to judge fairness could vary based on the implementation. And I think Brent might go into that a little bit more in how we're thinking about that. And if you do find any evidence of bias when you're auditing, the next step would be to test debiasing techniques. Sometimes the approach might be as simple as changing the proxy and seeing if that results in any less bias. And then there may be other approaches, more technical approaches that Brent will talk a little bit about as well. And then you implement. And it was not perfectly captured on the slide is the cycle really that goes between 4, 5, and 6. So implement, monitor for unintended consequences, continue to monitor for bias with any evidence of population drift or otherwise, and continually re-audit, retest debiasing techniques, and implement. And that as we're often doing from an algorithm performance point of view, iterating, seeing how our algorithms are doing in practice, iterating on them, improving them. We now have considerations of bias and fairness baked into that process. So with that, I will turn things back over to John and Liz, I think, for a quick Q&A, and then move over to a fireside chat.
Awesome. Thank you so much, Brian. And in part because I'm a very chatty person, we're running a little bit behind. And so I'd actually like to, we are acknowledging the questions that have started coming in. I'd like to push some of those off until the panel. So I would like to remind folks that Brent and Brian will both be on the panel toward the end of this tutorial. So at this point, let's maybe move to directly to Liz and Brent chatting.
Thank you, John. Hi, everybody. Great to be here. Wish we could all be in person, of course, but we will make do with what we have. So my name is Liz O'Sullivan. I'm the VP of Responsible AI at Arthur, and I'm so excited to introduce my colleague Brent Sundheimer from Humana. Brent, you and I work together fairly closely on the model monitoring part of Humana's tech stack when it comes to implementing these techniques at enterprise scale. And we've said all along that Arthur represents one part of the broader model governance ecosystem, and we talk about things a lot outside of those issues. But I'm curious if you could just describe a little bit for us the needs at Humana that technology has been able to fill. What technologies are you using, and or if not specifically those, what kinds of things do they do that you find helpful for your endeavors?
Yeah, thanks, Liz. So yeah, as you mentioned, we've been Humana's been partnered with Arthur to look at how do we check our algorithms for bias, not just at the initial construction of it, but also in the future for bias drift, because bias isn't a one-time thing. But that's just one piece of the puzzle. There is a fairly large tech stack that we use for our AI governance as a whole, because we do have a rather large organization, and our organization has a lot of models, as Brian had mentioned. And so part of this is is done from the standpoint of risk, right? And so making sure that the models are mature, that they're not going to break. But that has very much grown over the years as models have gotten more sophisticated, as we have understood more about some of the consequences of models, and models that may not be as mature as others. And so part of this is honestly as simple as a checklist. This checklist has as things like have you talked with the stakeholders about the problem that they're trying to solve, making sure that it's aligned, as simple as that, to um, having peer reviews that are structured and have some guidance set on who should peer review. There can be some undue pressure if the two people who are peer reviewing report up to the same person. And so in cases like that, time pressure could end up influencing the depth of that peer review. And so we have some checks in place to make sure that the peer reviews are done across teams, and that they really are deep and meaningful. Part of that checklist is also making sure that we have checked it for bias drift. And so we have a wonderful AI ethics operating committee that has been working to develop guidance on how we think about bias and unfairness in our models. And it's a very, very important part of the process, and it's growing and maturing as we continue to mature our ability to do data science and AI model creation. And so these are some of the pieces that we have in place, but there still are a lot of challenges. Being as large as we are, we work with a lot of third parties to help augment the good work that we're doing. Some of this is as simple as providing hardware, servers, things like that, but also algorithms, AI. So looking at chatbots. There are some companies out there who have some very, very sophisticated chatbots, or call center and virtual call center agents that can help to augment our own capabilities. And those also need to be checked for bias. Just because we don't produce it doesn't mean that we are free of the responsibility to make sure that what we're using is something that's fair. And to be quite frank, trying to monitor third-party algorithms is a really big challenge, and I think something where there is a bit of a gap in the tech stack in general, because they can come in a number of ways. You don't have the same controls in place for something developed externally than you do internally, and it really does present a challenge, especially as an organization is scaling up.
Yeah, no, I think that's a really excellent point. And as we all know, so much of the procurement process is where things can break down and these unknown unknowns take hold. But you guys are very hard on your vendors with regard to bias, especially, which I've been really impressed to see. But we all are kind of aware that technology is not a silver bullet answer to so many of these questions. There's so much other work that needs to take place, especially when translating these concepts into healthcare. One idea that has gained a lot of traction in terms of its ability to help reduce algorithmic harms is the simple practice of really good documentation. Really exciting, of course, that some notable authors of these exceptional papers like model cards, et cetera, are here at the conference and participating in a big way. With that, I wonder if we could poke at them a little bit, since this is an issue that you and I talk about quite a lot. What are some of the challenges that are unique to enterprise scale and to healthcare on a population level when you try to think about things like transparency and documentation and this research that approaches the reduction of harms in algorithms?
Yeah, so I think, especially at a healthcare company like Humana, something that we have to really work through is the fact that the people who develop the models have a very, very different skill set than the people who are going to utilize the models. And so the practitioners of data science can have a great in-depth knowledge of what the model does, its limitations, how it was trained, but clinicians who might be using the model, they don't have that. And it's something that we have seen as a challenge is how do you establish trust? Because if you have somebody who's very, very technical working with somebody who has a different skill set, there tends to be a bit of a gap of trust there, and that gap in trust is, I think, something that is important to acknowledge, and something that is important to really find a way to gain it. And I think, model cards is, I think, a very strong way to do it, because you're helping to share that information, to be transparent, to show the due diligence that was put into a model and the limitations of a model. And something like that is very, very important when you have a clinician, for example, who does take great care in their job, and really does have to learn to trust that what is coming upstream from them is reliable and isn't going to cause any unforeseen harm. And the more information that you can put in a way that is understandable, that a way that can resonate with them, is just going to help to enhance that. But we also have to keep in mind that trust can be lost, right? And so placing the limitations of algorithms in that model card will help to limit it to its intended function, because when models have very good performance, there can be a tendency for them to want to be used elsewhere, there is a risk that there may not be communication with the modeler themselves to using it elsewhere. And so I think, again, it's, I don't know if it's the best solution, but it definitely is a step in the right direction, and creating that standardized format that can become familiar to somebody downstream, especially someone who relies on multiple models to do their job, I think really can help to accelerate the deployment of AI and make it safer.
Yes, I think that's a really well said point, Brent. And I think that's with model cards as well. I think that translation of whether it is, certainly the spirit of it is very important. And now, some additional work needs to be done to translate it into your organization, which is kind of, for me, the fun part. And similarly, it's almost a trope at this point. People talk about how there are so many different definitions of fairness. And then even when you try to apply these definitions, you get into some really ethically fraught situations around, disease diagnosis or proactive intervention into healthcare outcomes. So I'm curious, how do you choose which measurements are the right measurements? And is that something that fluctuates over time?
So yeah, that's a very, very hard problem, and something that it's hard to honestly talk about very generally. But what I can talk about is just our thinking on how, what our approach was to narrow it down and to choose what measurements are going to be correct, or at least for our case. And so I think one way that we broke things down that really helped, not just to choose a metric, but to help people understand, to help people who may not be quite as familiar with the realm of fairness as others, is to break it down as equity versus equality. And so when we look at problems that we face, and the models are meant to solve, we first take a look: is this something that we think should be equal between everybody, or is this something that is driven by a need, where that need is going to be variable depending on the group of people that it serves? Is it going to affect people with disabilities more than not? Is it going to affect people who may have lower income? Is it going to affect people of different race? And this is a fundamental question that starts to drive that. But then, driving down deeper to that, we start to ask the question: what could be the underlying cause of harm? So, one example that I think many people have seen out there is, is there reduced accuracy because people with a darker skin tone may have a difficult time unlocking their phones with facial recognition? Is there a limited resource of value that's being given disproportionately to the privileged few? These are the type of questions that we ask to see, all right, is say demographic parity going to be something that we want to really focus on? Or is accuracy really going to be a key metric here? But I think something also that's really important to keep in mind is not just about the model, it's about how it's used. Right, because a model that is going to be used for one specific purpose may have a different answer than if it's used for something else. If you're trying to measure somebody's prevalence to engage with somebody on the phone, if you're trying to sell them a product, that's one thing. If you're trying to get them to buy into getting a vaccine, then that is something different. And so these are things that really need to be kept in mind. But I think it also goes beyond measurement, and redefining the problem statements in a way that, if possible, can remove any systemic barriers and treat people more inclusively. I think inclusive design is really an approach that can help us go beyond just a single metric to measure fairness, and often is also going to lead to better performance as well as better outcomes for everybody.
Yes, that's a really good point. And I love that you mentioned the notion of inclusive design because, of course, as we all know, all industries at enterprise scale, but especially at the healthcare industry, does face a pretty significant and concerning lack of diversity. So you and I and others at Humana have talked at great length about the commitment to diversity that you all have initiated and put into practice at your company. It's really impressive. I wonder if you could just talk a little bit about how you're working to resolve this in a really homogenized, otherwise situation.
Yeah, so I think when we're starting to talk about equity and fairness, that it's something that you can't do with just a small group of people, and it really has to be something that is done with a very inclusive and diverse audience who has the ability to feel safe to speak and speak honestly. It's honestly a challenge to set an environment to do that, especially because in these conversations, you're going to have people from legal, from HR, people from different areas of the business, and it can be quite quite challenging for somebody to feel comfortable enough to speak openly and honestly about it. It's something that we have worked to do, that will continue to make sure that people feel that sense of comfort. But I think that by taking a very focused effort on being and having a diverse audience, whether it be some people with different experiences, backgrounds, expertise, ethnicities, it's we want to make sure that as many different points of view are represented, because it's and it sounds kind of like corporate speak, but it's actually here. I think it's vital and something that you can't replace. And it's something that can't be done just naturally, and I think has to be done with a focused effort. And because it's hard to make sure that you are opening things up to different people and different voices, and you can't discuss fairness with just a limited few, because these are hard problems that affect people in very, very different ways. And I've been surprised at the different perspectives that we've gotten, and very pleasantly surprised. And so I think that we have seen a very great community that we have established really step up, and we're going to continue to work and grow on that.
Absolutely, and as well, the appointment of the first chief health equity officer at Humana, and your decision to abolish college and even high school requirements for diverse candidates and candidates who may not have otherwise access to higher education. That's a real commitment to me, to be able to train people and invest in their career to change the future, even if the past is a bit murky.
Yeah, absolutely. I was absolutely thrilled at that announcement, and it just makes me more excited to continue the work that we're doing here, because there is a commitment, and I think without a commitment from high up in leadership, any sort of fairness or equity program is just not going to succeed. You need to have that commitment, and I think Humana is definitely one of the companies who's shown that, and I'm definitely proud to be working.
Thank you, Brent. All right. Well, thanks everybody so much for this quick fireside chat, for joining us for today. At this moment, I'd love to open up to the remaining panelists, and that would be Lofred and Brian. Unfortunately, we were meant to be joined by Dr. Raman Chowdhury, but she is no longer able to connect to the internet right now. There were some technical issues, and she's still trying to join on, so she may pop in here any minute, but for now, it looks like it'll be Brian and Lofred. And John, maybe since there was a question for you from the audience, if you wouldn't mind popping on this panel in this internet-free zone. Great. And Lofred, thank you so much for joining us. I hope you're doing well, calling in from Paris today, right?
Yes, that's correct. Calling from Paris. Happy to join today.
Very good. Thank you so much. I wonder, since the other panelists have all introduced themselves to the audience today, if you wouldn't mind just taking a few minutes to give us a little bit more information about your background. For those watching, we invited Lofred because of his deep experience in actually attempting to regulate algorithms like this with the French government and his work at the World Economic Forum. But you're on to amazing things these days. Would love to just tell the audience a bit more about it.
Sure. So I'm project lead for the World Economic Forum, project lead for AI at the World Economic Forum, who very simply oversees various AI governance projects across jurisdictions. So I have projects in New Zealand, in the EU, but also in Japan. And I'm trying to work with government, businesses, and so forth to co-design governance frameworks. Before that, I was working for French governments already on AI policy. So I've been around that space for the last 5 years. And I'm one of the co-drafters of the French AI national strategy, and have a background in data science and philosophy. Happy to join today.
Great. Well, thank you so much. So to this panel, and again, I'd just like to open it up to the audience. We've seen some very good questions come in, and I will definitely attend to them in just a moment here. But I wonder, maybe Lofred, as the new panelist here on the Zoom call, if you could just talk briefly about what you would advise companies and practitioners to pay very close attention to when they look at trying to use fairness and machine learning and explainability and all of these technical strategies to try to mitigate or address bias and health inequity worldwide.
Well, my first my first advisory would be to focus on the context. We do know that risks are highly contextual, but somehow it is often missed when we have these discussions. My point here is there's no off-the-shelf solution that you can readily apply. Obviously, there are some issues that are common across use cases that you can conceptually approach. But it's really important to look at the use case. What is the AI solution you want to use? Who's going to be impacted? And looking at it really holistically, from the training data sets, from how the system was designed, how it is being used, and monitor its behavior when operation, so that you can then correct at certain points and ensure consistency with set of requirements. So it's really important to have a sense of what is the context and also how success look like. And I really want to insist on this. One of the defining challenges in machine learning, and I stop there, is that oftentimes performance is assessed on benchmark data sets. And sometimes, it's cut off from the broader social context in which the system is being applied. And that's the best thing to get things wrong from the beginning.
Yeah, I think that's a very good point. And luckily, I haven't seen too many pieces of technology claiming to be ethics in a box or one size fits all solution for these issues, because clearly there are different parts of the population that have unique challenges as they pertain to healthcare. Lofred, I'm going to pick on you one more time, just since the others have been with me for a while. I'm curious, what do you see as the most pressing concern when it comes to health inequity, if we look here domestically at the United States, but also from a global perspective? And how can machine learning help, if it can, help to ameliorate some of those inequities?
That's, I would say, number one is, one of my colleagues earlier mentioned human-centered design. And I think in healthcare, it's really critical, because if you're looking at how the healthcare system works, that's true in the US, but there are similar challenges, again, across the West, where my projects are mostly based. You will see that there is an overrepresentation, let's say, of some demographics in the files of, healthcare, the healthcare industry at the hospital level, but also across the entire industry, underrepresentation of minorities. That's really changing when it comes to drug discoveries, but also to the impact of various drugs on different demographics. Being an African American, you may react differently to various drugs, and this is understudied. That's an area where we have a lot of issues. So there's a paradox in healthcare. We have a lot of data. Actually, if we manage to clean the data, put them in the right format, and then aggregate the data with the right actors, there's governance changes regarding data in healthcare itself. But paradoxically, we're lacking data for some demographics, or there's so much unknowns for various part of the population. So I would say one of the challenges as well is actually getting the right data as part of the design of these solutions.
Amazing. I think you're totally right. And we definitely have the consensus here. I mean, this group inclusive design is not just an optional thing. It's absolutely mandatory, so that we can experience the lived experience of those who are actually affected by the outputs of the algorithm. I'm going to turn now briefly to some questions from the audience, but I'd love to get back to the boots on the ground, kind of the practitioner perspective a little bit later on. The first question was actually for John, since he was the first one to speak, and now I've scrolled long past it. So the question is, what advice would you give to technical folks who find themselves in a position where somebody would like to use your research? They find that your technical idea may be useful, but they don't have the option to speak to stakeholders. How else can they communicate this work?
I see. Okay, so is the question that you've come up with a good idea that you'd like to? I will interpret this as you've come up with a good idea that you'd like to at least discuss with stakeholders or potentially try to put into practice. And this is tough, right? So this is in part a networking question. It's in part a presentation question. So there is an element of course, serendipity to being able to meet folks, to be able to meet the right folks. Yeah, this is interesting. One thing that's been beneficial to me, at least, is to sort of broadly dabble in multiple communities. So one, I say this as, a computer science PhD who sort of rose up in the traditional computer science way, stack of degrees in computer science, and now I'm a computer science professor as well as a chief scientist at Arthur. So many folks in the computer science world will focus just on computer science venues. And that I don't think is right in many ways, unless you have, say, a pure computer science piece that you're not trying to pitch for a particular application. So something that we do, for example, is we'll publish at NeurIP, so we'll publish at a AAAI, and we'll present at INFORMS, which is for Operations Research and Management Science. We'll present at the American Transplant Congress, which is a very large gathering of transplant surgeons. We'll present at the World Transplant Congress, which is sort of the worldwide version of that. We'll present in venues like this. You'll write about this in blog posts that are easily sort of understood by other folks. But this isn't going to immediately introduce you to the right stakeholders at a particular institution. So it's tough because there is this element of serendipity, right? Like it's hard to build out that network, and the way to do that is a bit of this is bottom up, right? A bit of this is you are actively placing yourself in an ecosystem that's going to increase the probability of you meeting somebody, a cold meeting. Mm-hmm. And some of this should be top down, right? Which is you put something out there and maybe you leverage a connection that you currently have and you ask for a connection to somebody else. And this sort of flows down like that. And it's tough because I think of this as a stochastic optimization problem. This is all probabilistic, right? You can't go out there and guarantee that you're going to target the right person because you don't know who the right person is. And you can't make that connection, obviously, in many cases at least. And so there's this element of just sort of probabilistic increasing the chance of meeting the right people there that has to happen.
Thanks, John. I'm also going to focus a little bit. There have been a couple of different questions that ask about the technical aspects of explainability. So this is actually for all of you. I'm very curious about your opinions, as I'm sure they'll probably differ across the different stakeholder groups. What is your opinion on the technical capabilities of modern explainability? And of course, I'm focusing on the machine learning based techniques like LIME and SHAP. Some people say that explainability is mandatory and that it should be present in all machine learning. Other people say, well, if it works good enough, then maybe we don't really need to worry about it. So I think we're going to have a pretty diverse set of opinions here, but I wonder if you could each take a couple minutes to talk about, like, what are the limitations of this? Is explainability really necessary all the time, or is it something where it helps you guide your decision-making in a way that's fundamental, and so you really do need it in every use case that you endeavor to bring to life?
Yes.
I can call on some. Okay, Brent, you go first.
Yeah, I'll start right here. So I think that it's something that should be looked at for every model, regardless of the application, because it's a really good way to make sure, number one, that it's predicting in a way that makes sense. There's often going to be times when an algorithm might find a single feature that is going to really glue onto, and that's going to take the majority of the the reason on why it predicted there. But the more the more potential harm that an algorithm could cause, especially within healthcare, the more that I think it absolutely needs to be done, to the point that algorithm choice should start to change the more potential harm that there could be, right? And so if you're looking at something that is going to make a very fundamental choice on somebody, then going to, instead of a black box, more of a white box algorithm itself, and instead of trying to do it afterwards, I think is where people need to start going. Because we need to, SHAP and LIME, I think, have limitations. They do good for what they are, but they have limitations, and there have been some great studies that have shown that you can actually get a lot of your really unique insight based on the more white box algorithms, and use that insight to actually change the ways that you are approaching the problem in general. And so to me, it's something that should always be done, but needs to just have more focus, the more potential for harm or unintended consequences that there's going to be for a model.
Mm-hmm. Yep, I think that's a really good point. Definitely the risk factors into it in a big way. Wilfred, I feel like your opinion about this is going to be really interesting, especially coming from a European governance background. As we all know, the IC has taken some pretty firm stances on the need for explainability, but would love to just hear your take on the limitations and the promise.
Well, I guess, and if I can, I think it's a very important question. But somehow, I think people tend to focus a bit too much on explainability. Let's step back a minute, just a minute. Why do we need explainability before, right? As part of the GDPR and then beyond, like when you interact, think about any decision-making processes. Why you need explainability? Well, the short answer is like accountability. If something goes wrong, who's going to take the blame or responsibility for first getting a sense of how we arrived at that decision and coping with the outcome of that decision, right? Even on a moral standpoint, ethical standpoint, but also from like a liability perspective, you want to get a sense of who's responsible for that decision. I'm going to give you a really concrete example and then address your question. Imagine that you have these algorithms that can predict the likelihood of developing severe condition after getting COVID. That's a big deal. From an economic perspective and healthcare perspective, you can really improve the flow of patients at hospitals and apply that at scale. That's a really, really important piece. Well, you always have some margin of errors and so forth. But if you end up saying to someone, go back home, and that person developed this severe condition and ended up maybe dying, you need explainability, not only to attribute liability, but ultimately accountability at every step of a process, from the design of the systems, the physician. So we want to avoid in technological complacency. You don't want to have a physician to say, I've relied on this black box algorithm, so I'm discharged of my responsibility, and that's what happened down the road. That's the kind of thing we want to avoid here. And in that perspective, I think explainability from a strictly technical perspective is quite limited. As human beings, what we need is not just understanding the inner working of the model. It's about trust. And trust is about trusting institutions or people. It's a social phenomenon. So when you reduce trust to a technical mechanism or explainability or whatever it is, you sometimes miss ultimately the goal. So that's what I'm advising to governments or any private companies working on explainability. Again, key piece, but don't forget the trustworthiness and the accountability piece, because that's what people are looking for.
Excellent point. Very, very good point and well said. Brian, I wonder if you could talk a little bit about if explainability has helped you as a researcher and your opinion of the importance of it for the systems that you're creating at Humana.
Yeah, and I also just wanted to, I think, echo Lofer's point of I think just investing in explainability on the model developer's point of view is a signal of trust. And I think we saw, especially early in the pandemic with some sort of vaccine prioritization algorithms, that there was almost this sort of the lack of explainability was perceived appropriately and resulted in a lack of trust. And so I think it's such a critical point. Yeah, I think the explainability is interesting. I think from a general kind of AI best practices point of view, maybe taking fairness and equity off the table for a second, or just considering it separately, I'm maybe a little more appreciative of the view that sometimes you don't necessarily need to know, right? If the goal is just good prediction, the goal is good prediction. Sometimes that is the case. But when we think about implementing in a healthcare setting, we're often using algorithms to identify patients that need more help, someone for outreach, and especially when we are identifying patients that maybe need a little more attention, whether that's in the clinic or from a care manager, that doesn't tell us what to do so much. It maybe puts them higher on the list, but we don't know what to do to help them or why they need extra help. And that's where explainability is so critical, because it actually allows us, it helps with the next step. Well, okay, this person is high risk, this person needs our help. What do we do about it? What's the modifiable risk factor underneath that? And so I think there, from an implementation point of view, it becomes critical. But, and Brent was getting to this as well, I think, it is always essential in terms of the application and carryover on equity and fairness, because if we know that structural forces and structural inequality impact the underlying data, that's a given. And so if we find that a given feature is having an outsized impact on our predictions, we can then at least check based on our known biases if that is going to be causing a level of bias in the prediction. And so having a sense really for every data, or every algorithm, every model, what the sort of key features are to the extent we can, is just yet another check and ability for us to ask pretty critical questions about our underlying inequalities in the data going to drive disparate outcomes.
Yeah, I agree with you entirely. I think that's a very good point, that explainability in itself is not trust, but that explainability can be a tool that unlocks some degree of trust and knowledge about what's going on. John, I'm curious, can you round us out? Where do you fall on the spectrum of explainability is everything or explainability is nothing?
Oh, I will echo, I think, what all three. So Brent and Lofer, I think, really sort of emphasized this point nicely, and then Brian backed it up. It's one small component of a larger system, building trust or understanding how much one should trust, or understanding risk, understanding responsibility, assigning responsibility. It's one component of that greater system. So, the ML module forms a part of this greater system. Explainability methods, the Limes and the Shaps of the world, right? These focus on sort of wrapping around just this one small module, understanding or sort of an interpretation for input-output pairs for that model. But typically, I don't care, right? The downstream task is what I care about. I don't care about how well I'm replicating a particular model, or throwing a surrogate model on it that somehow explains to me what's going on. Fine. Like if I'm wrong sometimes there, but it never impacts me downstream, maybe that's okay. If I'm wrong just once, but right most of the time, but that being wrong just once is very bad downstream, then that's not great, right? So I think I'll say this from a computer scientist point of view, like melding that sort of upstream and downstream, components of the system into this explainability method, that's a good research challenge, right? Learning, there's a large space of possible explanations that one could give, right? One opportunity here would be to just use white box models, right? Like there is a a large contingent of the explainability community that believes that that is the right thing to do. And I won't make a normative statement on that, but I think there's a valid case for that for sure. But black box models will also be deployed because in some cases they do work better. And in a case like that, there's a large space of explainable methods that one could wrap around that. So how do we learn which of those we should use for a particular task, for a particular user, and so on? How do we incorporate that noisy downstream signal into the explainability method that we end up deploying or showing to a data scientist or showing to a different stakeholder, right? These are all going to be different. And I think that's a good research challenge that will involve necessarily machine learning researchers as well as stakeholders at every part of this pipeline.
Mm-hmm. Yeah, well said. Very excellent points. I'm curious, there are a few questions in the chat here, and just a friendly reminder to our audience, we still have about 15 minutes left. We still have time for questions. If you have additional ones, please do enter them into Slido. And some of these questions, I'm going to fuse them together because there's some naturally a interest in one of my favorite topics, which is privacy. And we all know that within healthcare, there are unique concerns around privacy that may or may not be at tension with AI. So I'm actually very curious, maybe Brian or Brent, could one of you talk about clinician privacy and your access to data and how that might or might not challenge your algorithmic work? Why don't we start with you, Brent?
Yeah, so it's something that we've had a lot of conversations about. And so the principle that we have really started with is a principle of least access, right? So we have data on millions of our members that is used as part of our push to really work with our members and improve their health outcomes. But how do you deal with that much data that is incredibly sensitive and incredibly personal in a way that is going to maintain that trust? And so the principle of least access is really what we start with, and saying, only people who actually need the access to that data are going to get it. But then we take it a step further and take some steps to do pseudonymization on the data itself. And so we take out all personally identifiable information so that we are not seeing anything about the member themselves. But kind of beyond that, what we tend to do is not look at singular members, right? And so the patient confidentiality really is around a singular person, but we're looking at the aggregate, and so we're looking at all of this de-identified data that has no personal identifiers attached to it, and looking at that aggregate in the majority of our models, and that's really something that's helping us to keep that data safe and making sure that we're maintaining that trust. But then we can actually take it there a step further, because we do want to have external partnerships. We want to have really meaningful research done with other companies, and we don't want to share this data as part of it. And so what we've done is we've brought up some capabilities to create synthetic data. And so this will create fake members with fake, with conditions that have the same distributions and relationships that our actual members have, but they're not real. And so then all of a sudden that data is a great tool that we can use to work externally with outside partners, with research, to really help to push the state of the art, and at the same time not increase any risk of that very sensitive and very private data to be released accidentally.
Very cool. Brian, anything to add?
No, I don't think so. I think Brent covered it.
Okay, great. Because I wanted to get to Lofred, because clearly there's a vast need for data in healthcare, and your approach as a regulator, I'm very curious. Well, when you're thinking about privacy in healthcare, how does that rationale work out for you and for other regulators that you've talked to? There has to be some sort of sacrifice, right, in terms of data collection. Additional data collection will help make the AI better, but at the same time, we're talking about some very, very sensitive information. So I wonder if you could just talk a little bit about that tension.
Exactly, and I will use like the same logic. Why do we need privacy for? Again, stepping back here. In healthcare specifically, there's an element of vulnerability for the patients. So obviously in the healthcare system, you already have this notion of stewardship, of guardianship from the physician, putting the interests of the patients at the center of his work. We want to replicate this element of stewardship in the data governance space. So move beyond privacy, because privacy is one element, obviously, but you also have cybersecurity. Really sensitive data, you want to make sure that it cannot be easily compromised or leaked, right? So it's not just about the privacy, it's all about from the whole life cycle of data. You want to have a governance framework that incentivize all actors, the designer of the solutions, the physicians, to put the interests of the patients at the center throughout the process of data collection, data use, access, storage, potential deletion. So that's the whole governance process that you want to put in place. And that's also what we've been pushing for at the EU level, but also what I'm seeing as a trend like across the West, New Zealand or Australia, that's kind of the same thing. So always when I talk to technologists, I think, oh, there's so many frictions. Think about the frictions, not like something meant to slow you down, but again, ensuring that you are, taking the best care possible with that, very vulnerable population. So, these are for me the most important things.
Okay, that makes sense. Thank you. And we have another question that I think I'd like to get all of your opinions on. So I'll call on you one by one since Zoom is not conducive to generating a natural conversation. But there's been a lot of conversation, both good and bad, because our field is our field, about impact assessments. And I'm curious about your views on the role that impact assessments can have in reducing harms. In particular, I'm curious about how do you define them? And this is a question also from the audience, but what are some of the challenges that you face when trying to build impact assessments for each algorithm? And more importantly, also maybe Wilfred, from you, not more importantly, but equally as important, I'm curious from your perspective, what role can these play? Will they actually solve some of the root causes that we're looking to ameliorate with reducing algorithmic harm? Are impact assessments a great weapon in this fight? Or are they potentially a little bit overhyped? Maybe we can start with you, Wilfred.
Thank you. Real quick on this, and I think it's a very important point. Impact assessment, again, think about holistically, step back again. So impact assessment is useful because that's an ex-ante policy intervention. You want to make sure that before deploying, it's kind of like part of your vetting process, whatever you want to call it. Before deploying your model, you want to make sure that you have kind of foreseen all the potential bad things that can happen. Obviously, the more you tie it up to the use case that you have in mind, the better you can identify the potential issues and have the strongest impact assessment. Two downfalls though. One is what I call the human factor. Again, don't get too caught in the model itself. Impact assessment should integrate also the training of a physician or the training of the users of a system and how it's going to impact interaction with the patients. And that's often like missed when you look at impact assessment. They tend to be a bit like too narrow. Second things, the future is always more imaginative. There will be things that you cannot predict from the beginning. So you need also some ex-post intervention. It might be an audit of a system, regularly auditing the system every once in a while, or the station over a form of intervention after the system has been deployed. So again, impact assessment is really critical, but that's part of this holistic approach of risk mitigation strategies.
Thank you. Thank you, Wilfred. And same question to you, Brian. How do impact assessments appear to help or harm or make better the work that you do?
Yeah, no, I love that approach. I mean, I think it comes back to what everyone has touched on, which is the importance of sort of intentionality from the outset, investing in what problem are we trying to solve. If you are pretty clear on what problem you're trying to solve, it becomes pretty easy to determine what positive or negative impact looks like. The challenges come in with that you can't do it. You have to do it on the ones, and you can't even do it for a single algorithm because it depends on the implementation. And that gets back to Wilfred's point about success is also not defined on the performance characteristics of the algorithm, but how it's actually used in practice. So I think it's essential, necessary but not sufficient, and it's more about, I think, process best practices than checking a box on a list of kind of technical exercises.
Brent or John, anything to add?
I think they covered it pretty great. For me, it's always trying to remind people that the algorithm does not exist in a vacuum, right? How it's used, how it's implemented, and then how it's constrained are all part of the greater system, and that's really where the impact comes from, not from the model. If a model has perfect performance but has a zero impact, it still is not useful, right? So. I think that it's the for me the most important part of the process.
I'm inclined to agree. Great. So another question from the audience, and this one's for Lofred. I'm curious if you could talk a little bit about how optimistic you are or you may not be about healthcare providers being able to use algorithms fairly and responsibly. As of right now, are you of the opinion that they're generally doing a good job, or is there a lot of work to be done ahead?
So let's put it this way, I haven't talked with enough practitioners to have like a definitive opinion on this, but I'm looking at incentives, because when you do governance, what you're interested in is what are the incentives of the actors to actually do the right thing, because you try to shape behaviors, right? So looking at the incentives, one thing I'm a bit concerned, if you're looking at the healthcare industry, especially in the US, how it is being financialized, and the interest also of not only the physicians, but ultimately the financial interest, what are at stake, and the inequalities that we already observe in the system. I think that we need much, much more governance in the healthcare system, I would argue, in the US, as opposed to what I see in most European countries. Not because people are bad, but as I said, the incentives there are fundamentally different from that of what I can observe in France, for instance. So what does it mean exactly? As I said, it's a really holistic approach. We need, obviously, the impact assessment, the training for the practitioners. We need better collaboration between practitioners and healthcare takers, but ultimately, we need a sound governance discussion in the US that involves patients, representatives. It involves caretakers, technologists, and government in a really truly multi-stakeholder fashion to put in place either some standards or regulation that will help the industry to move in the right direction. And I'm a bit concerned about this lack of regulation at the moment.
Mm-hmm. Yeah, that's a really good point. Anyone else care to comment? How optimistic are you about health and algorithms right now?
I think optimistic with the attention broadly, and optimistic, at least internally with our commitment. But I think the point about incentives is spot on. In a structure where we, algorithms we use to optimize within the incentives, and so for us at Humana, our incentives are through value-based payment and other mechanisms really focused on the best health outcomes for our members, and we have created our commitment to fairness and equity creates that incentive for us internally, and so I think you can't divorce it from that structure. I will say my biased view as a physician is that we are well intentioned and we went into the field to help others, and so it has been historically more of a blind spot issue than any malintent, at least for the vast majority of people. And so that's why I do actually think the awareness in this case is really important and actually gives me cause for optimism, because the underlying kind of innate drive to do what's right for our patients, for our members is there. We just have to make it a little more salient.
Mm-hmm. All right, folks, we are just about to end this session, so we've got about 3 minutes left. I want to leave on a positive note, so I'd love each of you just to comment what areas in healthcare are the most exciting where machine learning can genuinely help. I know there's lots of work being done in drug discovery, in COVID relief, in diagnosis, and other kinds of hospital management algorithms. But where's really the sweet spot as far as your research or your practice has taken you so far? And maybe we can start with Brent.
So I think that it's to me the biggest potential is the very biggest benefit to using AI, which is taking a look at lots and lots of data over long periods of time, right? And so we have this wonderful data set that goes over millions of people and does last for a very long time. And I think the possibilities to be able to find things that are not intuitive relationships that maybe weren't seen before, and use this large quantity of data to create next generation algorithms to really help prevent and discover new insights about healthcare is where it's at, because we're just now really entering into a state where people are starting to have access to large amounts of data in healthcare, right? So even though we've had, the last 10 or so years have been a huge growth in the ability to use big data, we haven't had access to the data because there just hasn't been any centralized place for it. But I think that we're starting to see a lot more prevalence of the availability of this data and availability of the data in a way that can still keep people's trust in their own privacy. I'm fairly optimistic over the next decade that there's going to be some really amazing insights and progress.
Amazing. Thank you so much. And Brian, maybe we'll go over to you for the last minute of this conference, this tutorial.
Yeah, high stakes. I'm not sure I need the whole minute. But no, I think that what I'm most excited about and what I'd like to see more of is more attention to using algorithms as a force for good. I think we've sort of, if you take the trajectory of the last decade or so, conceptual concern about algorithmic bias, documentation about algorithmic bias, I'm excited about pushing that forward to how do we use algorithms as a force for equity versus just attending to make sure they are not actively undermining our efforts at equity. And I think for us, an area that's top of mind right now is around COVID vaccination. And so, we're using machine learning and algorithms to identify our members or communities that are at risk of falling behind with vaccination rates, and then proactively target outreach to them. And that's just one example of a thread you could apply to so many issues in healthcare.
Awesome. Well, that's time for us. So I just wanted to say again, thank you to everybody who participated in this tutorial, and to you, everybody in the audience who's joined us today. We hope this was informative and useful for us. We'd love to connect with you later on in the week as the events of this conference unfold. We'll be available to connect for job opportunities or anything else you'd like to learn about Humana, the World Economic Forum, or even Arthur AI. Thank you so much.